Welcome back to another deep dive. Today, we're tackling a really common, but actually um, surprisingly complex medical condition.
Yeah, it seems simple on the surface, but there's a lot to unpack.
Exactly.
hmm
We've got a stack of revision notes here, specifically about laryngitis, both the acute kind and the chronic kind.
hmm
And our mission today is basically to turn these notes into a clear, high-yield overview. Think of it as a fast track, getting you up to speed on what's really important about inflammation of the voice box.
Sounds good. These notes are pretty comprehensive.
They are. They cover everything from, what laryngitis actually is to what causes it, how it shows up, and maybe most importantly, when it's something you really need to worry about.
Right.
So it's perfect material if you need to get a solid grasp on this quickly.
Absolutely. And we'll try and guide you through them. The goal isn't just listing facts, right? It's about connecting the dots.
Yeah.
We really need to break down that crucial difference between acute and chronic laryngitis because honestly, that distinction changes everything. And we'll explore the causes, which are surprisingly varied, especially for the chronic type, and pinpoint those critical red flags that mean, you need to investigate further.
So we'll follow the structure in the notes. Definition, causes. Okay.
Exactly. Pathophysiology, how it works, what else it could be, how common it is, clinical picture, checks, management, prognosis, and any potential issues. The whole lot.
All right, then let's dive in. Let's unpack this condition, starting right at the beginning. What is laryngitis at its core?
Well, at its most basic level, laryngitis, just like the notes define it, is simply inflammation. Inflammation of the larynx.
The voice box.
The voice box, exactly. And that's crucial because the larynx contains your vocal cords or vocal folds. So when it gets inflamed, well, the main effect is on your voice.
Which leads directly to those key things the notes mention. Hoarseness, changes in your voice quality, and often that sort of scratchy, uncomfortable feeling in the throat.
Precisely. Makes perfect sense. Inflamed vocal cords just can't vibrate like they normally do. But here's probably the single most important distinction right up front, and the notes really highlight this. It's about how long it lasts, the duration.
Right.
Acute laryngitis is defined as lasting less than 7 days.
Okay, less than a week.
Yeah. Chronic laryngitis, on the other hand, that's when it persists for more than 3 weeks.
More than 3 weeks. That's a big difference.
It's a huge difference. And it's not just some arbitrary time limit. It fundamentally changes why it might be happening and what you need to think about next.
Why is that duration so critical then? What changes?
Well, because the notes tell us the common causes are really quite different between the two. Acute cases, they're overwhelmingly linked to infections, usually viruses, think common colds, flu.
Okay.
Chronic cases, though, are much more likely to be down to non-infectious things. So just knowing how long someone's had the symptoms immediately helps you narrow down the possibilities. It points you in a different direction.
Okay, that clear time split less than a week versus more than 3 weeks, that's actually incredibly helpful. A really key point. So let's dig into those causes then. What are the usual suspects behind this inflammation, according to the etiology section of the notes?
Okay, so for acute laryngitis, the notes pretty much confirm what you'd guess. It's mostly viral.
The usual cold and flu bugs.
Yeah, exactly. We're talking rhinovirus, influenza, RSV, parainfluenza viruses, the ones that give you sniffles and a cough anyway. These bugs just irritate and inflame that delicate lining of the larynx.
Makes sense.
Now, the notes do mention bacterial causes are possible. They list things like Haemophilus influenza, strep, staph, Moraxella.
But less common.
Much less common initially, yes. The notes suggest maybe as a secondary infection, like after you've already had a virus, or perhaps in people who are immunocompromised.
Okay.
Fungal infections like Candida are also mentioned, but again, that's almost exclusively seen in people with weakened immune systems.
Right. So acute equals viral most of the time. Simple enough. But you said chronic is different, often non-infectious. What sort of things cause laryngitis that drags on for weeks or even months?
This is where, like you said, it gets much more complex, and the list in the notes for chronic laryngitis is pretty extensive and, well, diverse.
Okay.
Think about things that constantly irritate or cause trauma to the larynx. Smoking is a big one.
Yeah, I can imagine.
That constant irritation just damages the laryngeal tissue over time. Then there's excessive voice use or misuse, like shouting all the time, or professional singers, maybe teachers, if they don't use proper technique. That causes physical trauma.
Like wear and tear?
Kind of, yeah. Even just persistent coughing can contribute. And then there's reflux, specifically something called laryngopharyngeal reflux, or LPR.
Is that different from normal heartburn?
It can be. With LPR, stomach contents, maybe acid, maybe enzymes come all the way up into the throat and irritate the larynx. But you might not get that classic burning chest pain.
Ah, okay.
And the notes suggest this is a super common cause of chronic hoarseness that sometimes gets missed at first. Allergies, too, things like allergic rhinitis or asthma can cause ongoing inflammation in the upper airway, and that includes the larynx.
So it's not just acid reflux. Allergies can do it too. That's interesting.
Exactly. And the notes also list certain medications. ACE inhibitors for blood pressure, for instance, they're quite well known for causing a persistent cough.
Which then irritates the larynx.
Precisely. Inhaled steroids, the ones used for asthma, they can cause local irritation or even sometimes fungal infections like thrush in the larynx, especially if you don't rinse your mouth out properly after using them.
Right. Good tip.
Even things like antihistamines and diuretics get a mention, probably because they can have a drying effect on the mucous membranes.
Okay, wow. What else is on that chronic list?
Well, beyond those, the notes touch on less common but still important causes. Autoimmune diseases, things like rheumatoid arthritis or lupus, they can sometimes affect the tissues in the larynx. Sarcoidosis is another possibility.
Right.
And then there's physical trauma, maybe an injury or even being intubated for a long time, having breathing tube in, that can lead to chronic changes or scarring.
Gosh, so that list really tells you that with chronic hoarseness, you really have to play detective, don't you? To hunt down that underlying, often non-infectious cause.
You really do. It highlights why asking how long is so critical. It just sends you down completely different paths.
Absolutely. So given that huge range of potential causes, who's more likely to get laryngitis in the first place? What risk factors do the notes point out?
Yeah, the notes list a few key ones. Unsurprisingly, smoking is right up there, particularly as a risk for the chronic type.
Okay.
Excessive voice strain or misuse, we mentioned teachers, singers, maybe call center workers, that's another big one.
Makes sense.
Exposure to other irritants counts too, like breathing in chemical fumes or lots of air pollution. And maybe, obviously, just having had a recent upper respiratory tract infection, especially a viral one, significantly bumps up your risk of getting acute laryngitis. Your larynx is already a bit vulnerable,
Yeah, it's already irritated from the initial bug. Okay, so you know what it is and why it tends to happen. But how does the inflammation actually physically mess with your voice? The Pathophysiology section explains the mechanics, right?
Right, and the process described in the notes is actually quite straightforward when you break it down.
Okay.
When the larynx gets inflamed, that delicate lining, the laryngeal mucosa, it swells up. The medical term for that swelling is edema.
Okay, edema. Swelling.
And this edema, this swelling, directly impacts the vocal folds, those structures that vibrate incredibly fast to produce sound.
Right.
When they're swollen, the vocal folds just can't vibrate smoothly or, fully close properly. They become thicker, less flexible.
Right.
And that disrupted vibration is precisely what causes the hoarseness, the changes in voice pitch or quality, and sometimes even complete loss of voice. The notes also add that a viral infection can sometimes go a step further and directly damage the actual surface cells, the epithelial cells, lining the larynx.
So it really boils down to the swelling messing up how the vocal cords move. That paints a really clear picture.
Okay, now hoarseness is the classic symptom, and laryngitis is common, but it's not always laryngitis causing hoarseness, is it? This differential diagnosis section in the notes looks pretty comprehensive.
It is, and this is a really critical list for anyone assessing hoarseness because, well, missing something more serious can have big consequences.
Definitely.
So the notes start with the obvious one. You need to differentiate acute from chronic laryngitis itself. That's often the first step.
Okay.
But beyond that, you have to think about structural issues. Things like vocal cord nodules, polyps, or cysts. These are benign, non-cancerous growths, but they sit right on the vocal cords and physically interfere with vibration. They're listed right there.
So little bumps getting in the way.
Essentially, yes. Then there's GOD, or LPR, that reflux we talked about. We mentioned it as a cause of chronic laryngitis, but it's also a differential diagnosis because the symptoms, especially early on, can just seem like simple irritation.
And then, more worryingly, the notes include laryngeal tumors, which could potentially be malignant, cancerous.
That's a scary one.
It is. And that's exactly why persistent hoarseness, especially in certain groups, is such a potential red flag, linking back to those urgent cancer pathways. Allergic reactions can also cause sudden laryngeal swelling and hoarseness.
So it's not just inflammation from infection. It could be physical changes like growths or reflux or even allergies or tumors.
Precisely. And the notes actually go even broader than that, listing other potential causes.
Oh, Like what?
Well, they mentioned conditions affecting the cartilage framework of the larynx, something called chondronecrosis, narrowing of the airway itself called stenosis, either at the vocal cord level or just below it.
Wow.
Then there are iatrogenic causes, that means problems caused by medical treatment. Think scarring or nerve damage from previous neck surgery or radiotherapy to the neck, or even damage from a difficult intubation. Medications pop up again here, but listed as potentially causing direct effects that mimic laryngitis symptoms. Some antipsychotics, for example, can cause laryngeal dystonia, like involuntary muscle spasms affecting the voice.
Okay.
Warfarin, the blood thinner, is mentioned because if there's even minor trauma or strain, you could get a vocal cord hemorrhage, a bleed, which causes sudden hoarseness. Vascular lesions, like little abnormal blood vessels on the cords, are another possibility.
This list is huge.
It really is. And nerve problems, specifically paralysis of the laryngeal nerve, which controls vocal cord movement. If one cord stops moving properly, your voice gets hoarse. And finally, they mention idiopathic ulcerative laryngitis, basically. Ulcers in the larynx causing hoarseness, but where they can't find a clear cause.
It just shows, doesn't it? Hoarseness is just a symptom. You have to think really broadly, especially if it's not fitting that classic, quick, acute viral picture.
Absolutely. You have to keep that wide differential in mind.
Okay, switching gears slightly. How common actually is laryngitis? The notes mention UK figures in the epidemiology section.
They do. For acute laryngitis, the notes say it's very common, particularly in winter, which fits with the viral link.
Yeah.
The rough incidence they give is about 5.3 cases per 100,000 patients per week popping up in primary care. So, GPs see it a lot.
Okay, pretty common then. What about chronic?
Chronic laryngitis seems to be less recognized or maybe underreported, the notes suggest. It has a lower yearly incidence rate, around 3.47 cases per 1,000 people.
Still seems quite high.
Well, the lifetime incidence is what's really significant. The notes suggest it could affect up to 21% of people at some point in their lives.
Wow, 1 in 5 people potentially getting chronic hoarseness. That's substantial.
It is. And interestingly, the notes also found it seems to occur more often in women, the chronic type.
Okay, interesting. So that brings us neatly to the symptoms. What does laryngitis actually look and sound like? What are the typical things you'd see or hear based on that clinical presentation section?
Right. So the notes list the absolute classic symptoms of acute laryngitis, the ones most people would recognize. Number 1 is hoarseness.
The main one.
Yeah, ranging from just a slightly rough voice, maybe a deeper voice, to complete loss of voicophonia. There's usually a sore throat, often described as feeling dry or irritated, scratchy. A cough is common too, often dry. And maybe some mild discomfort or even slight pain when swallowing.
Okay, the core voice and throat stuff.
Exactly. But the notes also add these additional symptoms that often tag along, usually related to whatever underlying bug is causing it, like a virus.
Like cold symptoms.
Yeah, things like a runny nose, rhinitis, maybe more significant difficulty swallowing, dysphagia than just discomfort. That weird sensation of a lump in the throat that's called globus pharyngeus.
Oh, yeah, I've heard of that.
A persistent urge to clear your throat, muscle aches, myalgia, sometimes a fever, and just feeling generally unwell, fatigued, malaise.
So a whole cluster of symptoms possible.
Yeah.
But you mentioned earlier, and the notes stress this, there are serious signs too, the red flags. This part seems vital. What should listeners really be alert for?
Absolutely vital. The notes are very clear on signs that suggest the airway might be getting compromised or that something else more serious is going on. Difficulty breathing dyspnoa, especially if it seems to be getting worse, that's a major alarm bell.
Okay.
Stridor, that specific high-pitched whistling sound when someone breathes in, that is a critical red flag.
Why is that so bad?
Because it indicates significant narrowing of the airway right at the level of the larynx or maybe the trachea just below it. It means air is struggling to get through.
Right. Okay. I do.
Any signs of general respiratory distress, like using extra muscles to breathe, looking pale or bluish, they also fall into this urgent category.
Got it.
Now, the notes explain that for your typical, straightforward acute laryngitis, the diagnosis is usually clinical. It's based simply on the story the patient tells you, the history, and a basic physical exam.
What might you find on exam?
You might see a red-looking throat, what they call a hyperemic oropharynx, maybe enlarged tonsils. If the lymph nodes in the neck feel swollen, cervical lymphadenopathy, that might make you think a bit more about a bacterial cause, but it's not definitive.
Okay.
Very rarely you might see white patches or exudates, which could technically suggest something like diphtheria, but that's extremely uncommon these days in most places. And crucially, The exam is where you listen carefully for any hint of stridor or look for those signs of breathing difficulty.
So, history and exam usually clinch the diagnosis for simple cases, but let's really hammer home those red flags and the urgent referral points. When do the notes say you absolutely must dig deeper or send someone for specialist assessment?
Okay, this is really high yield stuff from the notes, definitely worth remembering. For a suspected cancer pathway referral, that means getting seen urgently, usually within 2 weeks, the notes specify. Anyone aged 45 or over who has persistent, unexplained hoarseness.
45 plus with ongoing hoarseness.
Yes. Or an unexplained lump in the neck. That's a key link. Chronic hoarseness plus age, or a neck lump, equals urgent investigation for potential malignancy.
Okay, very clear. What else triggers urgent referral?
Several other things listed. A history of recent neck surgery or radiotherapy, or recent endotracheal intubation because of that risk of injury or stenosis we discussed earlier.
Right, the iatrogenic risk.
Exactly. A history of smoking is a big factor pushing you to investigate chronic hoarseness more thoroughly, again because of the cancer risk. Unexplained weight loss alongside the hoarseness, another red flag for systemic illness or malignancy. Professional voice users, singers, teachers, actors, they often need referring earlier, even if symptoms seem less severe because their voice is critical for their job.
Makes sense.
And finally, persistent ear pain, otalgia, on the same side as the hoarseness, can sometimes indicate referred pain from a laryngeal problem. Significant difficulty or pain on swallowing, dysphagia or odynophagia, or just signs that the person is seriously unwell systemically. All of these should prompt urgent investigation or referral.
That list is incredibly useful. It really frames the question. When is hoarseness not just simple laryngitis? Those red flags give you the answer.
Precisely. It tells you when to step back from the simple diagnosis and think broader and act faster.
Okay. So given all these possibilities, especially with chronic cases, do you usually need tests for laryngitis? What do the notes say about investigations?
Well, the notes are quite clear that for your typical straightforward viral acute laryngitis presenting in primary care, investigations are not routinely required.
So no blood tests or swabs usually.
Not usually, no. It's treated as a clinical diagnosis, manage the symptoms.
Okay.
However, investigations definitely are considered in specific situations. For acute cases, if you strongly suspect a bacterial cause or something specific but rare like diphtheria, then yes, swabs for culture or maybe rapid antigen tests might be used.
Right.
But the list of investigations really expands when you're talking about chronic laryngitis, which makes sense, right? Because you're hunting for that underlying cause we talked about.
Yeah, the detective work.
Exactly.
Yeah.
So for chronic cases, the notes list a whole battery of potential tests. Things like blood tests, maybe a full blood count to look for infection or anemia. Swabs from the throat or larynx might be cultured. Serology tests if you're suspecting an autoimmune condition.
Okay.
Specific tests for infections like syphilis or TB might be relevant in certain contexts. If reflux is high on your suspicion list, pH monitoring is crucial to confirm it.
How do they do that?
Usually involves a thin probe passed through the nose down into the esophagus to measure acid levels over 24 hours. And then there's visualization.
Look at the larynx directly.
Yes. Indirect or direct laryngoscopy, using mirrors or flexible scopes passed through the nose or mouth to get a direct look at the vocal cords and surrounding structures.
Wow.
There's also video stroboscopy, that's a specialized scope that uses a strobe light flashing at slightly different frequencies to the vocal cord vibration. It creates a slow motion effect, which is brilliant for spotting subtle things like nodules, polyps, or problems with how the cords are moving.
That sounds quite specialized.
It is, and imaging might be used to neck x-rays, chest x-rays, maybe CT or MRI scans if you're worried about something outside the larynx pressing on a nerve or the airway. If complicated GRD is suspected, tests like a barium swallow or esophageal manometry might come into play.
So quite an extensive workup potentially for chronic cases.
Yes, but the notes stress that most of these more complex investigations for chronic laryngitis typically happen in secondary care, with ENT specialists.
Right. So simple acute cases usually need no tests, but chronic cases often require a full specialist workup. That makes sense. So how do you actually manage laryngitis according to these notes? What's the general approach?
Okay, so for acute laryngitis, the management described is primarily focused on symptomatic relief, making the person feel better while the body fights off the virus.
So what helps?
The key things listed are voice rest, and that means really using your voice as little as possible. Whispering is often just as straining, sometimes more so.
Oh, interesting. So silence is golden.
Pretty much, yes. Staying well hydrated is important, drinking plenty of fluids. Using humidification can help soothe the irritated tissues, like using a humidifier or even just steam inhalation from a bowl of hot water, carefully, of course.
Okay.
And over-the-counter pain relievers like paracetamol or ibuprofen can help with the sore throat discomfort.
What about antibiotics? People often ask for them.
Yeah, but the notes really emphasize that antibiotics are rarely needed for acute laryngitis because it's usually viral. They should only be considered if there's strong evidence or high suspicion of a bacterial infection, or in the very rare case of suspected diphtheria.
Right.
Corticosteroids, like prednisone, might occasionally be considered in non-diphtheria cases, but typically only if there are signs of significant airway swelling causing breathing problems linking back to those red flags again. It's not routine.
Okay.
And crucially, tying back to those red flags too, the notes mention hospital admission as a necessary step if there's severe airway compromise. That's not just about symptom relief, it's about safety, ensuring the person can breathe adequately.
So immediate safety first.
Absolutely. And the non-prescription measures listed just reinforce that core symptomatic care. Vocal rest, hydration, humidification, and just general principles of looking after your voice, vocal hygiene.
Okay, that covers acute. What about managing chronic laryngitis? The notes must say something different there.
Completely different approach for chronic because there you're aiming to treat the underlying cause.
Right. Find the cause, fix the cause.
Exactly. So voice hygiene advice and formal voice therapy with a speech and language therapist are often central, especially if voice misuse or strain is identified as the problem. They teach techniques to use the voice more efficiently and safely.
Okay.
Treating the underlying conditions is key. If it's GRRD or LPR, that means lifestyle changes, avoiding trigger foods, elevating the head of the bed, plus medications like proton pump inhibitors, PPIs, to reduce acid. If it's allergies, manage the allergies. If it's an autoimmune disease, treat that.
So targeted treatment.
Yes. And the notes mention that surgery might be an option for chronic structural problems like removing vocal cord nodules or polyps, but usually only if more conservative measures like voice therapy haven't worked.
Right. So acute is mainly symptom control, and waiting it out, chronic, is digging for the cause and treating that specifically. That's a really clear distinction.
It is.
What's the typical outlook then? The prognosis for laryngitis, is it usually a serious long-term problem?
Well, reassuringly, for acute laryngitis, the notes state the prognosis is generally excellent.
That's good to hear.
It's usually a self-limiting condition. It typically resolves on its own within days to maybe a couple of weeks, just with those simple self-care measures we talked about, voice rest, hydration.
Okay.
But the notes wisely add a caution. If symptoms keep coming back frequently, or if they persist beyond that 3-week mark, that should definitely prompt further evaluation, which links right back to thinking about chronic causes or those red flags we discussed. Don't just assume it's another simple viral bout if it keeps happening or doesn't clear up.
Good point. Does the source mention any prevention tips?
It does, and they tie back nicely to the risk factors and causes. Avoiding irritants, especially cigarette smoke, is fundamental for prevention, particularly of chronic laryngitis.
Makes sense.
For people using inhaled steroids for asthma, using them correctly is key. Rinsing the mouth out with water after each use, using a spacer device if appropriate, and making sure they're on the lowest effective dose, often given twice daily rather than higher doses less often. This helps minimize local irritation or the risk of thrush in the larynx.
Right. Simple technique makes a difference.
And general lifestyle advice for people prone to GRD, like avoiding big meals late at night, weight management if needed, can help prevent reflux-related laryngitis.
Okay, so some practical prevention points there. Finally, are there any potential complications from laryngitis? Any downstream problems mentioned in the notes?
For acute laryngitis, complications are fortunately pretty rare. The notes mention that uncommonly, if there is a bacterial infection involved, it could potentially spread locally. That might lead to more serious infections like a peritonsillar abscess, which is a collection of pus near the tonsil, or even supraglottitis.
What's that again?
That's a dangerous inflammation of the structures above the vocal cords, including the epiglottis, which can rapidly swell and block the airway. So, serious, but rare from simple laryngitis.
Right.
And while it's probably uncommon, the notes suggest that very severe or prolonged acute inflammation, especially if combined with continued voice strain, might theoretically contribute to the development of vocal cord nodules or polyps over the longer term.
Ah, okay. What about complications from the chronic type?
For chronic laryngitis, the complications listed are more about the long-term impact of whatever the underlying cause is if it's not managed well. So chronic hoarseness itself can lead to persistent voice loss or significant changes in voice quality that really affect communication and quality of life. Severe, untreated chronic inflammation or structural changes, like from long-term smoking or reflux, could potentially lead to airway obstruction over time or a persistent chronic cough.
Okay.
Occasionally, things like long-term trauma or inflammation can cause scarring that leads to laryngeal stenosis, that narrowing of the airway we mentioned. And very rarely, the notes mention severe infections like herpes simplex virus affecting the larynx could potentially cause significant tissue damage like erosion or necrosis. But again, these are generally uncommon outcomes.
Okay. So wrapping this all up, what does this journey through the notes really tell us? We've gone from the simple definition inflammation of the larynx right through to these quite complex scenarios.
I think the biggest takeaway is how that initial question, how long has this been going on, immediately splits the possibilities. You've got the usually mild, self-limiting, probably viral acute cases on one
I got a
side.
week.
Right. And then on the other side, you have the much more complex, cause-dependent chronic cases lasting over 3 weeks where you really need to investigate properly.
And we navigated that long list of potential non-infectious culprits for chronic hoarseness, reflux, smoking, voice misuse, medications, allergies, even autoimmune diseases. It really highlights why you can't just ignore persistent hoarseness.
Exactly. And maybe most critically, we've zeroed in on those vital red flags. Knowing when hoarseness isn't just hoarseness, but potentially a sign of airway compromise or, something much more serious like malignancy demanding urgent attention, that's crucial.
It really is. Thinking about it, just training yourself to automatically ask about duration and then running through that mental checklist, acute versus chronic causes, and those absolute red flags based on age, history, smoking, weight loss, neck lumps, associated symptoms like breathing difficulty or swallowing problems. It completely transforms how you approach that symptom.
It really does. It helps you filter when can you reassure, advise simple measures, and when do you absolutely need to refer urgently. It turns a very common symptom into a structured diagnostic challenge.
Yeah, a powerful example of how knowing the framework helps. So that wraps up our deep dive into the nuances of laryngitis, drawing heavily from the insights packed into these revision notes. We really hope this breakdown has helped clarify things for you.
Hope it's been useful.
And if you are tackling exams like the MSRA, or maybe you're just looking for more really comprehensive resources that are structured clearly like these notes, you can find a lot of detailed materials over at passthemsra.com.
And for even more revision support, including lots of free content to help solidify your knowledge on topics just like this one, make sure you check out freemsra.com as well.
Definitely worth a look. Join us next time for another deep dive into a new topic.